All right, everybody, let's jump back into this. So, when we're talking about chemotherapy, the effects that it has on the body for as like nausea and vomiting, a lot of patients develop an aura before before it starts. So it kind of just like depends on what's going on with your patient. Okay. All right. So nausea, vomiting, and diarrhea. What does the nurse monitor? Okay, so we're looking at nausea, vomiting, and diarrhea. We're looking at how they look, their presentation. Sometimes with nausea, you can kind of like tell with the patient because they just, how I want to put it, they just look like something is going on. They're constantly having like this, they're constantly spitting, they're having like this watery mouth, and they saying just it just doesn't feel right. Like that's that aura. And then once it progresses onto that, then now we have the vomiting. All right, the diarrhea is going to be there constantly up and down, in the bathroom, trying to use the bathroom. They're constantly running. Sometimes they can't even make it to the bathroom, and then it's just they're just coming out of both ends. Then what do we end up with? We end up with dehydration. That is something we do not want. So with dehydration, with that being said, we try to replace the electrolytes, like with Powerade, Gatorade. Sometimes the doctors will put them on, restart them back on different IV fluids. Depends on what's going on. If the potassium is low, we'll put them on, and depends on what the potassium level is. We'll put them on normal saline with maybe 20 of K, and it may go anywhere between 50 to 75 cc's an hour. Or sometimes if they're diabetic and they're thrown up and they just cannot eat, we'll put them on, they have to have potassium. We'll put them on D5, half normal saline with 20 of K or 40 of K or whatever it is they need. And it'll normally go up between 50 to 75 cc's an hour to try to replace those electrolytes and everything and make sure that their blood sugar doesn't bottom out, especially if they are diabetic. So things we're going to be looking at, we're going to look at the labs, pre and post medicative antiemetics. If they're throwing up, we're not giving them Zofran by mouth. We're going to give them Zofran IV. We used to give Phenergan, but Phenergan has like a big shortage of it. And a lot of our sickle cell patients like Phenergan as well. But we've gotten it where the oncologists, where we still can give it to our oncology patients. So the hospital normally tries to save the IV Phenergan for them, and then like elective surgeries that they know that the patient is going to be sick, that does not have chemo. They kind of like limited because there is a shortage of the Phenergan, IV Phenergan, but they do have the PO kind. Um, we're going to be looking at that. We're going to look at the anti-diarrheas, and we do have Imodium AD we do give, and we do have Lamotil. And Lamotil means to slow the flow, but Lamotil is given PO, and for some reason they have made it like a narcotic. We have to count it every time we pull it. We just can't. It used to be when I first started, we could just go in the Pyxis and get the Lamotil and go ahead on, but now we got to count it or whatever like that. And if something is missing, somebody's going to be getting in trouble. I don't know why we're counting anti-diarrheals now, but that's what we're doing now. You want to look at the I and O. We're going to wait. We're going to look at the mucous membrane. Make sure it's make sure that the mucous membrane stays pink and moist, that it's not dry. We want to teach them how to eat small, frequent meals. Not to try to eat all in one setting. To kind of like spread the meals out throughout the day. Another thing too, this is another tidbit. Depending on the type of medication or chemotherapy that the patient is taking, a lot of my patients tends to tell me that their food tastes like metal. Well, it's not the food that's tasting like metal. They're tasting the metal utensil. So that's what's making the food taste like it's metal. So I normally just go ahead just right out the bat, and I just go ahead and I tell them that, and I tell them to get them some plastic utensils and start eating with that so they'll be able to eat. And so when I start doing that, they're more able to eat, because if a patient is eating something that feels like it's a metallic taste in their mouth, they're not going to eat it. And it's not the food, it's the metal from the utensil. So I teach them to eat with plastic utensils. We're going to monitor for hypernatremia. We want to make sure that sodium is not out of whack. We want to make sure that potassium definitely is not out of whack. And we had a lovely lab when we kind of like talked about the effects of potassium. So we want to definitely make sure we watch that, especially in our patient, because we do know that the chemo can be cardiotoxicity, cause cardiotoxicity with their heart, and if the potassium is up and the chemo is affecting the heart, then we got a double whammy on the heart. So we definitely want to monitor that. And we're going to treat with the antiemetics. I kind of like told you about that. And we're going to pre-medicate if necessary, which we already do. So when they go home, we want to tell them to take the medication as prescribed. When they feel the first sign of nausea, take the medication orally or rectally. And yes, we do give the medications rectally. The patient, like I said, we're going to always give them nausea medicine before they take the chemo. We're going to give them sometimes that is going to be Zofran IV, or it's going to be Aloxi, which is another nausea medicine. I did not give that to you all in your prototype because it's not going to serve you any justice of it, because you won't see it unless you're an oncology nurse. We're the only ones that give Aloxi. Nobody else give Aloxi. So we also give a MEN. That's another one that helps for nausea. I did not give that to you as a prototype too, because once again, unless you're majoring in oncology, as you're going to specialize in oncology, that's the only reason why you need to know those drugs. So I'm just mentioning it to you as a tidbit here on the lecture. So we'll give that. It used to be where we used to give 32 milligrams of Zofran when I first started doing chemotherapy, and then as we start having a shortage of Zofran, so now we only give 16 of Zofran, and we give 16 of Zofran and 12 of Decadron, and we used to give 12 of Decadron, but now we're starting to get a shortage of this, so everything's kind of like dwindling down. So it's even now, because of the shortage of the IV Dex, now we're starting to, if the insurance say we can give them PO Decadron, now we have to give them PO Decadron, and now we can get them up to the prescribed dose that we can. But granted, if your patient is nauseated, how can I give them Decadron if they're nauseated? So it's just like kind of catch-22 kind of thing. And the main challenge is to always try to make sure that they stay hydrated. Hydration is the key. So I always tell my patients that they don't do anything else is to make sure that they're drinking at all times. Because obviously we got to get them to drink. Even though they don't like to drink, but they got to drink. It's very, very important. All right, so Zofran, this is one of your prototype. It's a serotonin antagonist, and we give this to help with the nausea. So you can see the profile sheet that I've been giving you all. We do have Zofran that can be given sublingually, and it goes up under the tongue. It melts, and it's the best because along with the IV, because remember, it's something that's really, really fast. It goes directly in the bloodstream. You don't have anything to worry about. Normally when we have to give it is 30 to 60 minutes prior to chemotherapy. So that's even if it's PO or IV, we always going to give it 30 minutes. We don't like to wait 60 minutes because 60 minutes is a little bit longer because everybody's body metabolizes things a little bit quicker. So we go ahead and give it 30 minutes prior to we're going to start the chemo, so we make sure they have it in their system. And it's given 1 or 2 hours prior to radiation. Now, I don't deal with the radiation part of it, but that they have radiation. The radiation nurses will normally will tell them when to take their medication if it's going to make them nauseated, especially if they're getting radiation to the esophagus or to the stomach. Okay, it can cause a headache, dizziness, and diarrhea. However, Zofran also can cause constipation, because remember, it slows that response down, so you won't feel nauseated or whatever, and it kind of like dries you out, so people can become constipated on Zofran. So I always tell my patients, if we send them home on Zofran as a nausea agent, to make sure that they drink plenty of water, take stool softeners, to take Miralax to help them go, because it can cause the constipation, let alone diarrhea. So an antiemetic choice such decreases sedation and euphoria is not as much as a Vescan for Phenergan. Phenergan can be very, very addictive for some because they think that they got to have Phenergan all the time, and Zofran does not work. However, when we're in the clinical setting, we don't give phenergan, especially to ones that we know that, because phenergan can be abused, believe it or not, because it has a sleeping effect and it makes you rest or whatever. Um, so that's another reason why we kind of like steer away from the phenergan, just because it can be addicted to some patients or whatever. All right. Let's talk about the phenergan. This is what phenergan can do to your hand, because it can be considered a vesicant, especially if it gets outside of the vein. When you're starting your IV, you always want to flush and make sure that it's not swelling, or if it's not puffing or anything, or leaking. Because if your IV site is leaking, then most likely that valve is probably leaking. Especially if you're giving phenergan, that's what it can do. It can do to the vein. It is a part of antihistamine. It does help with that. It can be given IVPO or rectally, but I have not given it rectally. It can cause extreme sedations and euphoria. It's very strong vesicant, and it can damage the veins, as you can see. So you're looking at this vein. This man's hands probably gonna be like this for a while. Outside of the dressing changes that have to be done. It is incompatible with many other IV meds, so you have to put it on the line by itself. It's very rarely given IV push anymore, and we do. I have never ever pushed IV vinegar. I've always, even if the doctors ordered IV push, I put it in a 50 cc bag and I let it dilute and just give it on its own. Um, there, like I said, there is a national shortage of the IV, so we kind of like steer away from it, and we try to save it for the surgery patients, or our patients that we know for a fact is going to be severely sick with the chemo. It, believe it or not, phenergan was originally introduced as an insecticide and as a drug to treat infections of parasitic worms in livestock and in people. It's no longer used for this treatment. It is degraded by sunlight and air, so it's not good an insecticide, but it's a good anti-nausea medication. So phenergan, that's why it's in a dark rectal. I'm sorry, in a dark ampoule. So we're taking something now that was used to kill parasitic worms in livestock like cows back in the day. So yeah, that's why we have all these issues or whatever. So don't get it confused. A lot of people like to get it confused with phenothiazide, which is an antipsychotic medication, and it is not. But like I said, we don't give it really on the floor anymore. If we give it, it's going to be in the pill form, and the most of the patients going to get in the pill form now is going to be 12 and a half. They're not even going to get 25 anymore. So, all right. So the things that can be affected that's imbalanced is going to be our calcium, magnesium, potassium, and sodium. The two that are very, very known out of, since I've been doing chemo for like almost 10 years, that I know that my patients have an issue with, really the three. It's going to be the calcium, the potassium, and the magnesium. So with potassium, we just give them potassium replacement. We'll give it to them IV. It depends on how much you're getting. If it's 20 milliliter equivalents, it only can be ran over in over 2 hours. If it's 40, 4 hours. If they have 60 milliliter equivalents, it has to be ran over 6 hours. And 80 milliliter equivalents, it has to be ran over 8 hours. Magnesium can be ran anywhere between 1 to 4 hours. If it's a 2 gram, they try to get us to run the 2 gram over 2 hours. If it's 4 milligrams they have to have, we run it over the 4. But it just depends on the patient and how low it is or how much you're going to get. But the minimum amount of magnesium they will get will be 2 grams a mag. Calcium, we do give calcium replacements drugs. We don't give them outright calcium. We give them the replacements, and one of them is going to be Zometa. Zometa is a calcium replacement, and what it does, it takes the calcium out of the blood, which would be considered hypercalcemia, and to put it back in the bones where it belongs. Okay, so that's one of the medication that we normally give with that. So, and then if the calcium is not too detrimentally low, where they don't need the Zometa, then the doctors will put that on a calcium PO supplement. And normally what I normally tell my patients just to go ahead and just take them a daily multivitamin every day that has so many milliliter equivalents of potassium, magnesium, what they need, vitamin A, B, C, all the B vitamins, all the D vitamins, calcium, and all of that. They take that every day religiously, then those patients tend to do better and they don't have any problems with those numbers being out of whack. So, like I said, we're going to monitor for hyponatremia and kalemia. We already know what to watch out for. We've already gone over the electrolyte lecture. We're going to look for neurocardiac and reflexes signs. So you already know what to look for is neuro, if the calcium and the magnesium. We've talked about all that with Miss Bridget. So that's why fluid and electrolytes is very, very important. And that's why we introduced that first to you all prior to us getting into these lectures. So if you need to go back and brush up on those electrolytes, you definitely need to do it because you will be seeing it on this test because it's very important because all this goes hand in hand with our oncology lecture. Fluid imbalance, you know what we need to be monitoring for. If it's fluid overload, fluid underload, if they have any kind of pitted edema, they're retaining onto the fluid. If they have any shortness of breath, you can hear the wheezing. That means they're wetting the lungs, they're holding on to it, they have a cardiotoxicity. Like I told you to, everything is getting backed up. The heart is not pumping like it needs to. Okay, and we're going to look for the fluid overload, fluid deficit. All these signs and symptoms go together with the chemo, with the dilution, concentration, the crackles, the pulses, the veins, the edema. That's why we do a full head-to-toe assessment before we do anything. Because if they have anything that's out of whack with their labs or any kind of edema or showing any signs and symptoms, any kind of distress, we cannot give them their chemotherapy. All right, so we're going to look at hepatotoxicity. What are we monitoring for? And this is the liver. This is your hepatic panel. We're looking at the elevated liver enzymes, like I said, and also you will see swelling. In the late stages of liver failure, you're going to see ascites, and it's going to look like, if it's a man or a woman, they're going to have like a really round abdomen from the front all the way around to the front, the back to the front. And you're going to also observe jaundice. And jaundice is going to be where you can tell if a patient has jaundice if you look at the sclera of the eyes. That's why we tell you guys to look at the eyes, because you'll see like a yellowish tinge. And they're going to look like a yellow highlighter, pretty much. The palms of their hands are going to be yellow, and the balls of their feet are going to be yellow. In an African American person, that's when you're going to be able to really, really tell it, because we're darker skinned, complected. And when our jaundice has gone far, that's the only way you're going to be able to know if our jaundice levels. You have to look at our hands and the bottom of our feet. Versus as our white counterparts, you'll be able to tell because their skin, they're lighter complected than we are, and they're going to be yellow all over. And then that's how you're going to know that they're more jaundice, and they're going to look like a yellow highlighter. So we're trying to give you like ways to be able to remember, to kind of like know what the patient's going to look like. So if you're not for sure if they're jaundice or not, depending on whatever complexion that they are, look at their hands, look at the bottom of their feet, because those are your lighter areas, and look at the sclera of their eyes. Okay. Nephrotoxicity, that's going to be with your kidneys. So with your kidneys, we're going to see an increase in potassium. And if the kidneys are not working, then we have SIADH. And we've already went over that, kind of like know what that is, because Miss Bridges talked about that with you all. And some drugs can also cause that with the patient. They can become toxic with their kidneys and in their ears, and they become toxic with their ears. You would be looking at ototoxicity. So with ototoxicity, I always relate it to a cowbell, because that's what my patient, they said, it feels like somebody have a cowbell ringing it in my ear. It's like they can't hear nothing. You can be standing in front of them, talking to them, and all they can hear is a cowbell sound in their ear. So all the people that are Mississippi State fans or whatever kind of fans you are, when they be ringing that cowbell, that's all they hear. It is just distinct. And so that's what they're hearing. So when we're looking at it, we can see fluid backup and the fluid overload. So we're going to look at the symptoms of the overload. We may see a decrease in the urine output with their kidneys. They even may develop a UTI, or they may even see blood in the urine. So they're going to end up having rapid tumor cell lysis after chemotherapy, and it can cause urinary problems, and it can also form uric acid. These cells also can destroy, and it can cause leakage, and it can cause potassium to be floating around in the bottom, which can cause the hyperkalemia. So we're going to make sure that we're looking, make sure they're not having any kind of hemorrhagic cysts. We want to make sure that we're monitoring their bladder. We know how much they're putting out. And I've told you all that the least amount of urine that a patient can put out in an hour is 30 cc's. So you're looking at 30 cc's in an hour. There are 24 hours in a day. So if you know how to do your multiplication, if that's all they put out in the day, then that is a medical emergency. So if your patient is on any kind of chemo and or whatever they're on, even if they're not even on any kind of chemo, we just need to try to kind of keep up with how much their body is putting out, because once those kidneys are damaged, there's nothing we can do. Now we revert it, and now our patient has to be put on hemodialysis. All right, so look at our GI ulcerations. All right, so we're going to monitor for sores, bleeding, gastric upset. They can lead to bleeding, decreased appetite, weight loss, dehydration that can be caused by not being able to eat or drink like they need to. With the GI, mucous membrane cells reproduces very rapidly. Therefore, the GI system may see some of these as evidence as a part of the chemo. So you always want to make sure that you're checking and looking in their mouth. Pulmonary fibrosis, we're going to be looking at the things we need to be looking for, like a decrease in the O2 status. They have hypoxia cyanosis. When they're cyanotic, what color are they going to be? They're going to be blue. They're going to have blue lips, blue nails. That's how we always teach you how to do the capillary refill. They're going to have long-term damage with the respiratory. So with some drugs that can cause pulmonary toxicity, there can be changes in the lungs, which includes in the capillary leak syndrome. And this is where the pulmonary edema occurs in certain drugs. And so we're going to look for a sudden onset of shortness of breath. They're going to have this deep, raspy cough. Sometimes it can be productive and sometimes it's not. If it's productive, then it's going to be like a thick kind of mucus kind of set that they're going to have. All right, they can have cardiotoxicity. We talked about that. Bradycardia, tachycardia. They may need pre-medicated and cardiac meds. Some chemotherapy drugs can affect the DIG levels, so we're going to make sure we monitor no labs in those cases. Okay, so with cardiotoxicity, we always want to make sure that if a patient has a known cardiac disease, we want to monitor them closely. And sometimes the doctor has to reduce the doses. And it has been times where my patients they go into their PCP, or they have a cardiologist that's already involved in their care. I always tell them to let them know that they're starting to take chemo. That's with anything, because chemo affects everything. I always tell them, I say, do you see an eye doctor? Okay, I'm gonna need you to go ahead and make an appointment with your eye doctor. We give them a list of their medication, chemo that they're on. Let them know that you're taking chemotherapy. So when you go back and you start having vision problems, they can either determine if it's chemo related or is related to just aging of the eyes. If they have a cardiologist, we always want to make sure that the cardiologists know that what type of chemotherapy they're on. And then that's when the cardiologist and the oncologist need to kind of like coordinate the care of the patient, because either the doctor needs to increase their heart medication or they need to decrease the dose, or the oncologist need to decrease their dose of the chemotherapy that they're getting. Elderly patients are more at risk for cardio toxicity, because remember the age of the patient. The older you get, things tend to slow down. Their body tends to hold on. Their body is not metabolizing things out like we normally would do. Okay. All right. So alopecia. So when looking at alopecia, this is usually reversible. It can be an emotional and upsetting thing to patient, especially our women. Our men, too much, they don't care nothing about it or whatever. It's mostly our women. And that's the first thing. If you want to throw a woman into depression about chemotherapy, the first thing on ask you, am I going to lose my hair? I do not give them any false hopes. I would tell them every patient is different. I would tell you, do not go shaving your hair off because you may or may not lose your hair. However, if you're washing your hair and you start to see big chunks of hair coming out in the sink or in the shower when you're washing your hair, then yes, most likely you're going to lose your hair. If you're just seeing just normal shedding, then no, most likely you're probably not going to lose your hair. But it's pretty much up to you. Certain, if we know for a fact certain chemo is going to make them lose their hair, like adriamycin, that is like it kills everything. I'm completely honest with my patients if they're on adriamycin. If they ask me, I'm going to lose my hair, yes, you're going to lose your hair, and it's normally within the first 21 to 28 days. If they're on any other type of chemo, like cisplatin, Taxol, Taxotere, any of those things, some people do, some people don't. So I don't, yeah, those are the ones I normally tell them it's up to you what you want to do. I can't say if your body's going to lose the hair or not because everybody's body is different. But if it's one that I know for a fact, which like I said, adriamycin, I know for a fact that my patients are going to lose their hair because it's the strongest out of the strongest. That's why they call it the red devil. I know for a fact that they're going to lose hair everywhere, all over their body. Wherever hair is on them, they're going to lose it. So I'll go ahead and I'll let them know. And especially with our women, if they're getting adriamycin, we have a lot of churches that are here in the Jackson area, like First Baptist of Jackson, First Baptist of Madison, and Byram. They have like a excellent ministry that do a lot of knit hats for our cancer patients. It doesn't matter if you're a man or a woman, because they do all just generic, just general colors. They do like the little hats, and we also have a wig shop, and we American Cancer Society. We give them that number, and they can set them up with different wig shop areas that's in the area that do help cancer patients to buy hair pieces. And then we have a lot of women that don't mind rocking the head. And then even after they become in remission, they have not had any hair for so long, they just continue to keep their hair shaved even when it comes back. I do tell them when their hair do come back though, that because they've had the chemotherapy and it does alter the different response in their body, their hair color is not going to be the same. I've had people that hair, they was a brunette, hair came back, it was red. I've had people that hair was black, their hair came back all white or it was gray. Or I had a blonde and it comes back and they have black hair. So it just depends on how the chemo does the body for us, the pigmentation and the melanin of the hair when it does come back. But with that being said, alopecia is one of the biggest thing, and it can become an emotional support. And some women, they do go into a deep depression when they lose their hair. And thus, that's when we kind of like set them up with our clinical psychologists. They come and talk to them. And we as nurses, by us being females, because it's all females that work in the clinic that pretty much just the chemo, we kind of like talk to them. And we already have things already set up for them in bags and set them up with support groups and stuff like that for them. All right, so peripheral issues that we're going to have, they're going to have the tingling in the hands and the feet. It's going to be like a numbing, stabbing pain, especially with our diabetics, because yes, we do have diabetics that get chemotherapy and they have the peripheral neuropathy, and we always have them to correlate of what if they already have it. I said, okay, you already have peripheral neuropathy? So if it gets worse than what it is now, because you know what your baseline is, then it's chemo related. I need you to let us know. So cisplatin is known for peripheral neuropathy and hearing loss due to the damage of the acoustic nerve. Okay. So the chemotherapy is neurotoxic and of course peripheral in the nervous system. And it is irreversible because once the damage is done, it is done. So it can cause a tingling in the lips. It can cause discomfort, tightness, and even in the throat. So we always tell them once they notice it, if they've never had peripheral neuropathy, we tell them to let us know right then. The medication of choice that our doctors put them on is gabapentin, which is Neurontin. Gabapentin helps with the nerve pain and it helps with the tingling so they can be able to function. And we really, really try to do extra teaching with our diabetics, because we do not want them to walk barefooted, period, anyway, by them being a diabetic, but definitely if they get chemotherapy, because if they step on a rusty nail or they step on something and they don't know and they have an issue, then guess what we got? We got some other issues going on. Okay. I had a patient over the weekend that's is a really, really bad diabetic. He stepped on a rusty nail. He did not know he had stepped on it. He had some bad shoes. He was outside walking on it, and he has the nastiest sore up on the bottom of his foot. So we have like this foam kind of skin cushion on it as well to help regenerate the skin. Was been on it for like 3 weeks, and he is not having any kind of effects from it. That's how bad his diabetes is, or whatever. So it's like now they don't know what they're gonna do, but now they got him on an antibiotic prophylactically, so he does not set up any kind of infection or gangrene in their foot, because it is not healing at all. And this is like the third wound care treatment they've tried to put on to try to get it to heal. Because it's on the bottom of his foot, they can't do a wound vac on it because he won't be able to walk or whatever, So it's like they're trying to do treatments to kind of help him be able to still move around. But he been a bad brittle diabetic, it's hard for him to heal. And that wound on the bottom of his foot, because it went untreated for so long, it's the size of a 50-cent piece. Okay. All right, so cognitive impairment. We have this thing, it's called chemo brain. Yes, they do get to the point where they do not remember different things. They can't remember. So a lot of people consider chemo brain, and this can be neurotoxic. But if it's to the point where they start falling, they just can't remember nothing. They can't remember their name or anything like that. So we do a full cognition health assessment on them before we even start the thing. We like, what's your name? Can you tell me your name, date of birth, where you live? I mean, just general random question we always ask them to kind of like see if they can remember. And that's kind of like our baseline or whatever. When we start seeing a decline, we always let the doctors know, and they pretty much do the same follow up with them as well when they're taking care of them in their clinic. Reproductive, you have your testicular and ovarian functions that can be affected. Most men do have their sperm harvest if they are of age where they know they want to have children before they start chemotherapy. That's because they have to have it harvest then. Some women, if they have to have chemotherapy, they may have their eggs harvest. And counseling may be needed in order to do this. So normally what our doctors do, if they're of their age and they don't have any children, they go ahead and they set them up with the doctors that are able to harvest the sperm and the eggs for them before they even can start the chemotherapy. Because once the patient starts the chemo, they still need to use some kind of form of birth control, like condoms, or some kind of like IUD or something like that, while they're getting their treatment, because neither partner needs to does not need to get pregnant or try to get the other partner pregnant during the time of chemotherapy, just because it can cause effects to the fetus. Okay, so this is the chest port. We talked about that. Chemotherapy is best delivered through the central line. Peripheral lines can be used, but with caution. So usually a port is put in, and if you're getting peripherally needed, then you need to ask why or whatever. Like I said, some chemotherapy we can give that's not that's not hard on the veins, and like I said, there's going to be your patient that's just getting like a monoclonal autoimmune type of medication like a Vivo, Uavor. Those are autoimmune types chemotherapy that's helped to boost the immune system. So they're not hard on the vein, so we can give those peripherally, but anything else, it needs to be given through a port, through a midline, or through a PIC. Okay. All right, so with vesicants, if you remember back in the earlier slides when I was telling you about the young man that the nurse had pushed the adriamycin, his arm, if you go down to the wrist of the arm to where this wound is here, that's how far up his arm they had to go in and do a skin graft on there. They had to remove all that dead tissue from that. I had another patient, I had another nurse that was there. A patient was getting adriamycin, and he didn't make sure that the needle was in the port. Actually, it was not even in the port, it was inside the skin. He had completely bypassed the whole port. After I had told him that the patient needed a 1 1/4 inch needle because she was a heavy breasted lady, and he didn't listen. And then when her breast started to swell, he wanted me to come in and look at it. And just me walking in the door, I knew that the needle wasn't in the port just from where it was sitting. So when I laid her back to feel around and kind of like look, and I was like, okay, this is not in the port. We got the doctors and all them involved and everything and stuff. And so, needless to say, the lady ended up losing her breast because the adriamycin had ate all the way down to her muscle in her breast, and the breast that ended up being removed was the breast that wasn't even affected with the breast cancer. So she had to go through all the surgery and breast reconstruction and stuff like that. And then, of course, because it was an error on the nurse, that his malpractice insurance had to pay all of that. So with that being said, things happen. If you're talking to somebody that's very experienced and they're telling you that you need to do something, and if you're a novice nurse, then 9 times out of 10, you probably need to listen to that. And also, with that being said, when you guys graduate from school, please get you some malpractice insurance to cover yourself, because this nurse malpractice insurance had to cover all of her hospital bills. His insurance also had to pay for her reconstructive surgery, because when, like I said, the breast she ended up losing, it got all the way down to her breast plate past the muscle. That's how bad the adriamycin went down in her tissue. Okay. So if you see this happening, which you won't because your patient should have a port, but if you do, you want to stop the infusion immediately, notify the physician, and follow the hospital and facility protocol. So some of you probably asking me, well, is there an antidote to this medication? Yes, there's adriamycin. However, adriamycin, the antidote, because it's far few between, because everybody knows the adriamycin should be given in a port correctly, and you're supposed to be getting blood returned back. The antidote is so expensive for one vial, which it only cares about 10 cc's, which is 10 milliliters. That one vial is over $6,500. So that's an antidote that you just can't willy-nilly just have hanging around, unless you're a big facility like UMC, John Hopkins, a big teaching facility where you can offset some of that for teaching purposes. So yes, we do have an antidote here in the area, which we will have to borrow it from UMC, because UMC do carry those medications for their teaching purposes with their medical students. So yes, if we would have known that this was going to happen, they only would have had 24 hours in order to get the antidote in her. And when she started exhibiting, all of the issues were a week or so later, because we ended up having to admit her, and her breast had gotten the size of 10 footballs. That's how big her breast had got. So the surgeon had to immediately go in and remove it to keep it from even going all the way down, where she would have had a big gaping hole in her chest. So it ended up, it was really bad. But she's alive. She's one of my patients. I see her all the time. She, at the first, she was not bitter about it, but she's okay now, or whatever. She talks about it or whatever. And it's just one of those learning things. So it's like, if you ever get to the point, if you're as a nurse and you feel like you know more than what somebody's trying to tell you, you are a dangerous nurse. And needless to say, that nurse was a dangerous nurse and still is a dangerous nurse. And this nurse is still practicing as an oncologist. However, he is a nurse practitioner now. So with that being said, I don't think he's going to learn from his mistakes. Some of the doctors have tried to take them under their wing to try to help him. But sometimes some people are just a lost cause. So when we're teaching you guys stuff, we're not teaching you just to say we're teaching you. We're teaching you because we want you all to be safe nurses and serve advanced nurse clinicians when you get out to practice. So if you ever wake up one day and you think you know more than anybody else, then it's time for you to find you another profession. Okay, so this is methotrexate. It's a folic acid. When they're taking methotrexate, they have to take folic acid along with it. And sometimes we put them on a B12 injection as well, because sometimes it affects the B12, the B vitamin. It treats several different types of cancer. It can be given orally or IV. It can cause problems with the bone suppression or cause problems with your GI tract as well. So I've given you folic acid. That's one of your prototype medications. And methotrexate is too. So I will tell you guys, you need to go ahead and make sure that you look at that drug as well on your prototype. Cisplatin is a platinum compound drug. I've given you the handout on it. It's one of your phenotype drugs. It's used to treat multiple types of cancer. Cisplatin is one of those ones that's really bad on the kidneys and on the ears. Normally with cisplatin, we will hydrate them with 1,000 cc's of normal saline pre and post. So they get a bolus of normal saline over 2 hours, the 1,000 cc bag. Then we give them their pre-meds, and then we'll give them their cisplatin. And the cisplatin normally runs over 1.5 hours to 2 hours. And then they have to sit there another 2 hours and get another bag of hydration of normal saline. And we try to do all of that to make sure that we've done our part to get them a good hydration. And we want to make sure that they take enough drink enough fluids while they're out. So we kind of like push that too. It can cause severe nausea and vomiting. So this is the one that we would give them Zofran at IV, and we would give them a MEN, which is the other nausea medicine, and we would send them home on actually 2 other nausea medicine. We'll send them on Zofran PO and Zofran suppository, and we'll also send them home on Compazine, which is another nausea medicine. All right, so let's walk through caring for a patient with chemotherapy. We've talked about the complications that can happen with our patients. We want to make sure that they know what to anticipate and what to expect. We want to always talk about the prevention and early detections in it. So that's where your health screening and the health fairs come about. We want to make sure that we're monitoring them and they know what to monitor for when they're at home, and to make sure that they have a good understanding of what's going on. So we always send them home with different resources. We send them home with handouts. We send them home with phone numbers to call. We give them our number in the clinic. They should have the doctor's office number to call if they have any issues or any problems. Anti-cancer drugs, adverse effects. Like I said, we're going to have the bone marrow suppression. They're going to have nausea, vomiting, anorexia, where they don't want to eat, GI disturbance, which is going to be your nausea, vomiting, diarrhea, constipation, alopecia, and they need to avoid pregnancy at all costs. Our role as cancer management, we need to know the labs, know your labs, know the normal, know what's abnormal is very, very important. So cancer interventions, C is going to be for comfort. A, alternate body image. We talked about that. They're going to have distorted body image. We need to make sure we're teaching them about their nutrition, what they can and what they cannot eat, and how to eat. We need to make sure they understand the ramification of taking the chemotherapy and the side effects. We want to evaluate their response to the medication when they're there with us and when they're at home. And we want to make sure they have respect for caretakers. A person can take care of their family member for so long, but they have to take care of themselves too. So if I'm taking care of my parents 24/7, 24/7, who's going to take care of me in order for me to take care of them? And that's what we have, the respite care, and that's what we have, the home health. They have like sitters and people that can come out and sit with the family members as while the person that's taking care of them can go out and do some things for themselves. All right, nausea, vomiting. We want to also know the numbers. The number one side effect of chemo medication should be expected. So how we're going to treat it? Like I said, we're going to treat it 30 to 60 minutes prior. Zofran and phenergan, but like I told you, phenergan is limited, so we try to steer away from that. And we always tell them to continue 24 to 48 hours after the chemotherapy. However, if somebody comes in with me and I've given them nausea medicine, and if they nauseated before they go to bed, always tell them, make sure you take it. If you're feeling nauseated, take the medicine. That's the whole purpose of taking it. Other interventions are going to be eating small meals, teach the patient how to cook meals, make sure that they don't not cook anything that's unpleasant smells. If they have somebody that's cooking for them, tell them to kind of like let the scent kind of die down before they present it to the person that's eating it. I know with our patients in the hospital, if we know if they're getting chemotherapy, before we take the tray in, we take the lid off the top of the food to kind of like let that scent kind of die down, and then I'll take the tray in there. Because if you lift something up in the food, automatically the scent hits you in your face, it's gonna make you nauseated. Make sure they're doing excellent oral care. Make sure they're washing their mouth, drinking plenty of fluids, or whatever. Just make sure they're just having good hygiene. And if we do all of these things, this is going to decrease the anxiety of them thinking that they're going to remain sick and get sick. Anorexia is can caused by the metabolic need from the cancer. We want to make sure that they're getting the right amount of oxygen that they're getting, the nutrients that they're needing. If they're diabetic, we want to make sure we're always checking their blood sugars. We want to make sure that their appetite is not suppressed. There is a medication, it's called Medgase. And doctors don't put the patients on unless they start losing extremely amount of weight. And that's another reason why I did not put this on here, because unless you're going to be an oncology specialist, I'm just going to give you these medications tidbit. You won't be tested. I'm just kind of like telling you about it, just in case you're with me in clinicals or with any other instructor, you kind of like know what it is. Medgase is an appetite enhancer. It is a white liquid. Granted, it is expensive, but a lot of the doctors have begun to lobby to try to see if we can get this where insurance does not make it expensive for our little patients. But they take it once to twice a day. It's normally 400 milligrams daily, or up to 400 milligrams twice a day, but they won't take it no more than twice a day. And we tell them to take it like 30 minutes prior to eating. We want to make sure that they're eating, they're drinking fluids like they need to. We want to encourage them to eat, monitor their weight, which we're going to always monitor weight, and we're going to always encourage them to eat protein. And one of the labs that you guys can look at when we're out, if you're not for sure if your patient is eating like they're supposed to, because they can tell you that they're eating, that's subjective, but what we see will be objective. That's what we see. Clinically wise, you're going to look at that albumin level. And I told you what your normal albumin level is and what it should be. And if it falls below that, then we know that they're not eating like they need to. And like I said, you always want to look in their mouth, make sure they don't have any kind of mucosis. And that's when they have the mouth ulcer and lesions and the thickness like thrush, like how the babies have on their mouth. If they have any of those in their mouth, they're not going to want to eat. Fatigue, we talked about the fatigue. They're normally going to become fatigued during the third day after chemotherapy. Fatigue also can be caused by if they don't have enough blood storage. If their H&H is really, really low, they may need blood for that, or the doctors may need to put them on an iron supplement, or they may have to have a blood transfusion. We want to teach them how to take periods of rest to conserve their energy. Don't try to do everything all at once, to try to delegate different things that they can. We want to make sure promote they get 8 to 10 hours of sleep. The more sleep they have, the more rested that they are. We want to make sure they let them know when they're not asleep to get out of the bed, because the bed is associated with sleep. If they're not sleeping and they're lying in the bed, and when they are sleeping, they can't go to sleep because they've laid around in the bed all day. So we want to get them up and moving around, sitting in a chair, sitting in a recliner, doing something outside of just laying around in the bed. I also tell my patients if they're having a hard time sleeping, they can take Tylenol PM over the counter. Some patients, we tell them to take Benadryl, because the Benadryl can help with the sleep aid. And if you look at Tylenol PM or Advil PM, if you look at the ingredients on the back of it, Benadryl is in it. That's what helps with the sleep aid. Sometimes I tell my patients they can take melatonin. Melatonin is a natural source, because melatonin is something that our body automatically produces, and sometimes it can be low on that, and they can take the melatonin. Sometimes I tell my patients they can drink a warm glass of milk, and it's like the pheromones that's in the milk. It's like a calming effect over the body, and it can help them rest. They can drink tea, warm tea. can also help them, has the antioxidants in it that can also help relax the body and get the body ready for sleep and promote rest. All right, alopecia. This is the hair loss. Like I told you, some patients they have a hard time with it. Some don't. Some people will rock the wigs or the hats or the scarves. So you want to teach them the facts behind the hair loss. When it comes back, what to expect. Teach them how to use mild shampoos. We want to make sure to avoid any kind of dyes, any kind of perms, any kind of chemicals to put in their hair. They need to kind of like stay away from that. Um, Especially if they're getting chemotherapy, and if it's one of the chemotherapies that do not cause hair loss, you want to tell them to stay away from the chemicals and start using mild shampoos and soaps because we don't want to irritate the scalp or the skin. Mucositis, this, like I said, this is the ulceration that's in the mouth, and you can kind of like see what it looks like. And this is exactly what my patient's mouth looks like. That's why I kind of like put a picture on it. It can last up to 7 to 10 days, and it can last longer if the patient does not let us know what's going on with them. And so this is what's going to lead them not drinking. This is going to lead them to not eating. This is going to cause dehydration, and this is going to make them sick and nausea and vomiting. They're going to end up in the hospital with us. So treatment is going to be, we're going to teach them how to brush their teeth after meals and at bedtime. If their platelets drop below 20,000, they need to stop brushing. They need to stop flossing and to prevent hemorrhaging because their blood counts are low. And we pretty much kind of like tell them what to be looking out for. When in the beginning, we tell them to stop using alcohol mouthwashes altogether. We tell them to use like a mild mouthwash like biotin. It has that in there, and then our American Cancer Society, they send like little samples of different things, and we give to them so they can kind of like know what they can use and what they cannot use with their mouth. When we tell them to use a soft brush or toothbrush, use like Sensodyne toothbrush because your teeth is going to become very sensitive. There is a medication called Maybix that we can give the patients for the mouth ulcers and the mouth sores, and it's like a swish and swallow. And I always tell my patients, if it's on your tongue and it's in your lips, most likely it's probably in your throat. So I just tell them to go ahead and swallow, and it has a little bit of lidocaine in it. And what it does, it numbs that area so they can be able to swallow. Because I've had patients that tell me that it feels like razor blades that are down their throat once they begin to eat. So that's it's a swish and swallow. They can do either or. My patient like to swish it and spit it out. And sometimes it depends on the severity of it. It's in their mouth. When I look at it, I'm like, okay, yeah, your mouth looks pretty bad. Let's go ahead and let's swallow it to be on the safe side so you'll be able to eat. Okay. And then normally, they normally have to take their regimen up to 10 days for that. So we want to make sure that they're doing just good hygiene care to the mouth, and we're doing our assessment like we need to with that. We want to encourage pure fluids and food intake. We want to encourage soft, bland, cold, non-acidic foods. And normally how our patients know they got a mouth ulcer or they're beginning to get one is if they're drinking tomato juice, orange juice, if they're drinking grapefruit juice, or they're drinking a cold soda, or they're eating spicy foods. That's when they normally notice that they have this mucosa coming in their mouth. We tell them if they notice it that they need to make sure that they take their dentures out, and we need to make sure that we get a good start on trying to heal those areas up. Because if they're eating with their dentures, all they're doing is constantly rubbing the sore in their mouth. So we're going to give them medications, like I said about the Maybix. It has the lidocaine in it, and so it's going to help with that. And then we want to just make sure that they do that. And sometimes the patient may end up developing a thrush in their mouth, which is a yeast infection. We may have to put them on diflucan, which is an antifungal. And if it gets too bad in their mouth with a PO form, they can't swallow. We end up have to put them in the hospital for up to a week to get the IV diflucan or Flagyl. Okay, so the infections, we want to talk about that. We want to make sure we continue with the good hand hygiene. I told you guys we normally give the Neupogen. It's going to help stimulate that to make sure they don't do that. We tell them to make sure they avoid different crowds. If they know people that are sick, if they're sneezing, coughing, or whatever it is, they don't need to come visit them. This is during the time that some family members get in their feelings when their family member has been diagnosed with cancer because they feel like that we are being mean. I've had patients, family members call me and say, well, such told me that they can't have any visitors. I said, that will be correct because their white count is low, and we have medication that we're giving them. And if you are sick, know they do not need to have any visitors. Talk to them over the phone. You do not need to see them face to face. I'm trying to keep your family member alive. So yes, that's why I told them no, that nobody can be around them. And my patient counts are really, really low, and I send them out to go home. I let them know, don't stop by Kroger, don't stop by Walmart, don't stop by the beauty shop. It goes directly to your house, and do not come back out. And I tell them that. Now, during that time when they're neutropenic, they cannot have any fresh flowers. They can't eat anything that is raw. If they eat any kind of fruit, it has to be canned fruit, or it has to be something that can be peeled. They cannot eat the apple raw, like some people like to eat the hull of the apple. They have to cut the hull off. It has to be washed thoroughly, cut the hull off, and they can eat the apple then. But we prefer them not to eat any kind of raw fruits or vegetables when their white counts are low. They need to take daily baths. We tell them to take their baths. They want to use a mild soap, like I told you guys in the beginning. They want to use like a mild soap, like Ivory or Dove, something that does not have a perfume scent in it, because we don't want to sit off the gag reflex, where they're going to be like they're feeling nauseated. So the different things I tell them to use, try Dove, to try Ivy. Caress is good because it's good on the skin. However, they have the scented kind Caress. They need to stay away from it. They need to stay away from the liquid soaps to bath in, because they do tend to have a little bit of the perfume and the additives in it that can be hard on the skin. So everything that they use, they want to use kind of mild of. If your patient have any kind of indwelling catheters, especially if they have bladder cancer or anything like that, we want to teach them good hand hygiene for us, like cleaning themselves and the Foley catheter. And if they're in the hospital with us, you should know how to do period care without any problems. And we're going to be giving them high calorie foods with that. And we can give them antipyretics and analgesics that's going to be able to help with any of that. What the main thing is, we want to make sure that they're avoiding crowds. We want to make sure they're doing everything they're doing for hygiene. And we're going to do the same thing if they're in the care with us in the hospital. Bleeding can cause, like we said, the thrombocytopenia. I kind of talked to you guys about that, where they're going to have the petechiae, which is the little red little spots, which that is normal. That's going to happen with chemotherapy. But the things that we're looking for is spontaneous, like bruising that's bigger than the size of a quarter or a dime that has spread it widespread. They need to come in. We're going to tell them to monitor that closely. They need to monitor for different nosebleeds. I tell them if they have a nosebleed where it takes longer than 2 minutes to stop, they need to come in. When we do our venipunctures, their platelets are low. We need to make sure that we're applying good pressure on them. And that's normally when we use the Coban. If I start an IV on a patient and I know their platelets are a little low, when I take their IV out, or if I do labs and I put the cotton ball and the Coban on, I tell them to leave it on for a couple of hours to make sure that they've stopped bleeding. I tell my men patients to no longer use straight razors to shave themselves, if they need to use electric razors. Want to make sure that they're using good things to wipe themselves per se. I've even told some of my patients they may want to start using like baby wipes or those flushable wipes that's kind of sensitive on the skin, especially when they're wiping themselves so they won't wipe or do a tear. You want to make sure that when they're brushing their teeth, they use soft bristle toothbrushes, like I said, then avoid flossing altogether when their platelets are low. We're going to always check those when we're doing their labs before we're able to do anything for giving them any type of chemotherapy. Other things that can happen with the chemotherapy is estrangulation. This is when the chemo are vesicants and they can cause this and they can cause cellulitis. However, like I said, this is not going to happen because all of our patients now, they pretty much have ports that have to get vesicants. But even with that being said, if it's just a regular chemo, this can still occur because we don't know about the veins, because some veins can be weak and we don't know that they're weak. That's why when we're giving chemo or any kind of medication, you always want to check your IV site to prevent any kind of cellulitis or any kind of infiltration. So that's why you always want to do this. And we will do warm compresses and elevate the extremity. That's even with normal saline. You can have a patient that's just getting regular normal saline, and they can have infiltration where the vessels of the vein was weak and it was leaking, and we didn't know it until we came back to do an assessment. We saw it, but once you see it, immediately stop it. Do your warm compresses on it and change your IV sites on it. And when it's just normal saline, the body will dissolve it on its own. The issues that you're going to have is when you have antibiotics or any kind of other medication that have caused the infiltration, that sometimes we may have to do an antidote or do something a little bit different because the body may not dissolve the medication like it's supposed to. When we're looking at hyperuremic, these are going to be the damaging of the cells. And that's when I told you guys we're going to be monitoring how often the patient urinates. And sometimes we may have to put them on a medication called sodium bicarb because now they're in metabolic acidosis and we need to make them back alkaline again. You see how all of that started to come into place. So you just want to make sure that you're monitoring the kidneys. We're going to be looking at those labs. We're looking at the CBC, the CMP. We're going to be looking at the BUN and creatinine. So you guys need to know what your normal BUN and creatinine is. And the normal creatinine ratio is the one. Just brush up on those labs because these are the things that we're going to be looking at. When we're looking at the hand and foot syndrome, and this is going to be like a sunburn that's going to be associated with certain type of chemos. That's what it becomes. The chemo there becomes toxic. That means that the medicine has pretty much leaked outside of the vessels, and we didn't know. We probably still had good blood return and everything, especially in the port. And it's going to look like they have stuck their hands in hot water, and we have to constantly put ice packs on them. So I've only had one patient out of my years of doing oncology that had the hand-foot syndrome, and his hands wasn't as bad as his feet. So it's like while we had him up in the recliner, like every 30 minutes, we had him to sit his feet like in those little basins that we have, and we just had him to stick his feet like in the cold to kind of like help with that, to apply the ice pressure on it. And we gave him the analgesics for that, and we had him on a PCA pump because he was in excruciating pain. And once we got it like kind of dissolved, we kind of backed off the PCA pump, and we ended up transitioning him over to PO pain medication. Okay, and this is supravena cava syndrome. This occurs in patients with supravena cava and block and compressions. And this can develop slowly over time. So that's why you want to make sure that you're looking at your patient. And as you can see, this is a medical emergency. So you got to look at where's your supravena cava, where is it located at? In your neck. So where's your heart? Everything, all this stuff is like can cause issues with the heart if you're not getting good circulation. Like I said, this is the medical emergency. You see how the man's neck is completely swollen. You see how his veins have become distended. They have the puffy eyes. Everything is completely bagging up. So you always want to make sure that you're paying attention to that. And it also can block the airway, requiring air support, and that patients end up being put on a vent. So what are some of the causes of it? It's most common diagnosed with patients that have lung cancer or non-Hodgkin lymphoma. The tumor in the chest may compress on the supravena cava. The tumor may grow into the supravena cava that can cause the blockage. If the cancer spreads to the lymph nodes and it goes to the supravena cava, the lymph nodes itself can enlarge and cause a blockage in the vein. It can even cause a blood clot in the vein, which can be caused by a pacemaker wire or intravenous catheter, which is flexible tube, which is placed in the vein to help. So you always want to just pay attention to if your patient have a pacemaker or anything like that. These are the things that can cause SBCS. So we just want to be mindful of that when we're taking care of our patients. And that's why it's diagnosed normally through a chest x-ray or through a CT scan. And normally if you're doing your good health assessment and you're listening to all your lung fields and you're listening like you're supposed to, and you're checking your patient over, you'll be able to spot it and be able to kind of like pinpoint something is not right with this patient. All right. So these are some of the symptoms that you're going to be able to see in the patient with supravena cava. So difficulty breathing, shortness of breath. They're going to have a coughing. So if you're treating chest pain, swallowing, swelling, respiratory, skin color, and voice should improve if you're treating it. Other symptoms are going to be like the hoarseness, fluid backup in the arms, fast breathing. They're setting like 80 something percent, and they're on oxygen, not getting good perfusion. The skin has turned blue. The vocal cord has paralysis. And if you see this in a child, it's always an emergency and requires immediate assessment and treatment. Okay, if you see this in a child. So treatment of it's going to be radiation chemotherapy, reduce tumor size, raising the patient's head bed. We're going to give them some steroids to help reduce the swelling. We're going to give them some Lasix, and they may get it, and we need to monitor the output of it. Because thermolysis is a treatment that break up the clots. And so normally may have to put them on a heparin infusion, or they may have to get Lovenox, which is another treatment. Most likely it's going to be heparin, and then we're going to switch them over to Lovenox. They may have to have a stent placed, especially if it's an area that's going to, if they're prone to having blood clots. And sometimes surgery has to be done to get rid of the blockage. So to know if the treatment is improving, you need to be able to assess the patient to determine if the patient is getting better. So you need to know what your baseline is and what's going on to determine if they're getting any kind of improvement. So we have tumor-like syndrome, and this is when the potassium, phosphorus, and uric acid in the BUN is increased and the calcium is decreased. We also can see tumor-like syndrome in patients that has non-Hodgkin's lymphoma, and that's because the bigger the burden of the tumor, how big for its degrade, will determine if they're going to react to the Rituxan or not. So Rituxan is not one of the drugs I don't think I gave you all, but Rituxan is made from rat protein. Okay, that is the treatment of choice for non-Hodgkin lymphoma is Rituxan. And how we know our patient is going to react, like I said, is based on the tumor burden of it. And how we know if their tumor burden is high is because they're going to be on a very extremely high dose of Rituxan, and the order is going to say you must run this over 5 to 6 hours. You can't run it less than that. So when those orders are strict like that, we already know that they're going to react. So the only thing that we normally give Rituxan is 650 of Tylenol, and we normally give 25 of Benadryl, and we wash them like a hawk. Now, some patients, they can have a high tumor burden. They may not react. They can do good with just those pre-meds. However, some of our other ones, they do not do good, and we end up having to stop the reaction, stop the chemo, within like maybe 2 hours of giving it, because they can react within the first 15 minutes to 30 minutes of getting it, all the way up to 2 hours. Normally after 2 hours, if they have not reacted, they're not going to react to it at that moment, but they still have a chance to react if they keep getting the treatment. So if they react within that time, we stop the chemotherapy, and we have a protocol that we give them. Then we give them 20 of Pepcid, we'll give them another 50 of Benadryl IV, and we would give them 20 of steroid. We'll wait 30 minutes to maybe an hour, depends on how bad the reaction was. Sometimes it got to the point where we had to put the patient on oxygen. They walked in, and sometimes we may have to admit them in the hospital because they just can do it. And sometimes the doctors will want us to re-challenge, and we try to re-challenge the patient, and they get worse than what they are, even without those pre-meds, then they are not a good candidate for Rituxan. But Rituxan is one of those ones, it can cause all of these issues, and it can be fatal. So it's like when we have a patient that has to get Rituxan, they have to come into the clinic first thing that morning, like at 8 o'clock. So if anything go on, a doctor needs to be able to be accessible to us, so we can be able to get orders, and if we have to take the patient and admit them in the hospital. So if you look down here on this link that I've attached, so you can kind of like know what tumor-like syndrome looks like, I would tell you guys to do that. And yes, if they react to that, we have to stop the chemotherapy, and we bolus them with like 1,000 of normal saline at $9.99. They hurry up and try to flush it out of their system, because if they're going to react, it's going to affect their kidneys and their potassium, and then it's a lot. It is a lot, and we have seen patients that react to this the tumor-like syndrome, where we have to end up putting them in the hospital, and say like their potassium was like normal, like 3 before they got it, and then like the next day they've been in the hospital, and we check on them, their potassium is like almost 6. and they have to put them on all kind of medication to get the potassium out. That's how bad tumor-like syndrome can be. So just click on that link and you can kind of like look at it and see how it occurs and how it affects people. Okay, radiation therapy is used to cure, to shrink, and to put patient in remission, and can always also can be done as a palliative care. Another type of radiation is called gamma knife, and that's normally with our patients that have had issues, metastasis to the brain. And we have one gamma knife facility that's here, and that's at CMC, which is Merit Health South off of Chadwick. They have gamma knife. I'm not for sure if it's another place here, but I know that's the one we normally send our patients to, where their tumor has metastasized to their brain and they have to have gamma knife. We send them over there. But 6% of the cancer patients receive some type of radiation. And that's normally when the tumor cannot be removed surgically at that moment because it may be too big, and they try to get it shrunk down enough where they can do the surgery. So normally if my patients, if they're doing radiation, radiation is normally 5 times a week for up to 4 to 6 weeks, depends on the size of the tumor. I've had some patients that even go up to 8 weeks of radiation because they may have multiple spots of it. Now, with that being said, if you have a patient with radiation, they do put the markings on the patient with radiation, and those markings cannot be removed. This is a thing right here, like someone with the gamma knife. Those markers cannot be removed, and they try to put the markers on, and they try to put like a transparent like tape on it so the markers won't go away, because they want to make sure that when they're doing the radiation, that the radiation is going in the area that it needs to go in when they do the radiation. So we try to teach that if you have a patient that has radiation marks to the chest, their skin is going to be very, very dry. They're going to have like burning to the skin. They're going to have acid reflux really bad. If they have markers to the belly, they're going to be more prone to have GI upset and diarrhea and constipation just because of that, because that's where the beams and stuff are going. Then you have your telehealth, which is your external radiation. This is a therapy they administer daily, every other day, and prescribes amounts. And you have your brachytherapy, which is your intraoral radiation, is delivered dose of radiation in a localized area. These can be considered done in needles, rods, or seeds or beads. The ones that normally receive the seeds and the beads are going to be our patients with the prostate, or our young ladies that have uterine cancer, if that's what the type of radiation that they want them to have. When they're doing the brachytherapy, the smaller dose of radiation is given over a longer period of time. It is more effective that hits the cells going directly into the DNA synthesis. Visitors' time should be limited up to 30 minutes. Pregnant healthcare workers should work with these patients with extreme caution. And when caring for these patients, stay as far away as little as possible. Now, with radiation therapy, any kind of exposure is very important. You kind of like stay away from them. So when brachytherapy, we used to do inpatient, but everything now, like I said, over the years past, is pretty much on an outpatient basis. So we tell them who they can and who cannot be around. When they normally have this, we tell them to go home. Do not go to the stores because they already were active. And a lot of our patients adhere to it. And if we feel like that they are not going to adhere to it, we put them in the hospital for their safety. So like some nursing diagnosis for our patient with radiation will be altered skin integrity due to the burns that can occur and the dryness of the skin. They can have skin alterations that can lead to infections, alopecia, especially if they have to have the gamma knife therapy to the brain. It can also cause anorexia and fatigue and malaise. Late effects are common so they can have bone issue or fractures, especially if they have to have radiation to the leg or the thigh, depends on what's going on, and it can throw some of our women into early menopause. Okay, radiation therapy, as you can see, those like the little beads and the seeds that are placed. We put them on bed rest, it's commonly prescribed. We put them in a private room when they put on brachytherapy. And if it's a patient that's on brachytherapy that is on, and we know that they may be non-compliant and not adhere, we have to set them in a room that's at the end of the hall, that's far away from other people. And whatever nurse that has them for that day, we try to make sure that it's them that's pretty much going in there. They have a set nurse or caregiver that's going in and out that's taking care of them. Um, and we try to make sure they don't have any exposure to their family members. And some family members get kind of upset and they want to visit. No, you can't. I'm sorry. So they all rooms now are gonna be private room, but we put them those type of patients at the end of the hall. We want to log roll them to make sure that the device does not become dislodged. We put them on our low residue diet to make sure they don't have any kind of issues with diarrhea. We assess the skin for breakdown and the burning. We do not wash any off any kind of markers, and I kind of like told y'all that. We're gonna monitor their appetite, and we want to make sure that we're doing everything that we're supposed to. And a pregnant nurse at the time, they are not allowed to take care of this patient, period. They can have fatigue. We want to treat the burns. We want to wash everything slowly with warm water and not hot. We want to do not use soaps that can irritate the skin. So that's why I was telling you about the mildness. So this young lady, these are all the areas because the skin can become burned. So she was getting radiation, looks like, to her chest, and it just extended all over to her neck, and she could have been getting it for a lymph node that was on the side of her neck, both sides of her neck. We do not use ice or cold compacts on these burns. And we do not use lotions unless it's ordered by the doctor. And it's a special kind of lidocaine cream that the doctors order for them. And it's very, very expensive. So it's like a last resort. But if the burns is really bad and it's irritating, because you got to look at, now we got a diagnosis for body image, because they have all these issues that's going on, because this can last up to 6 months. And that's even with treatment. Okay. All right, so we're gonna look at stem cell transplant. Treatments for stem cells is gonna be depends on the different patients. They have to have bone marrow, and they have to be a match, and I think they have to have so many matches when they're going to do stem cells. So if you look at the different types of stem cells that are there, in the definition of how you look at it, it can be very costly, and it's less dangerous for the donor than it is for the person that's receiving it. Because one of the news anchor, I can't remember her name. Oh my God, I can't. And that's the crazy thing, because I used to take care of for the longest time when she was one of them. But she's Channel 3 News. She was on, and gosh, I can't think of her name. When I think of it, I'm gonna let you guys know. But I took care of her, and I was the only nurse that took care of her. She wouldn't let anybody else take care of her for some reason or whatever. But I took care all the time, and she ended up going to MD Anderson. She found a match that was a 10-10 or whatever, because they had to be a 10-10 match in order for you to be in order to get the bone marrow transplant. Well, she ended up passing away. She ended up living to see her youngest child, which her child should be like a sophomore in college now, because we had our kids were the same age. And she lived to see the child go to college. That was her biggest fear. She didn't want to die until her child graduated from high school and was able to, she wanted to see the child at least get 1 year going to college. Well, that was during the time when she first got diagnosed. Her baby, the baby, which was him, he was like in the 10th grade. So she was able to do all this. And when she had a bone marrow was when he first went to college or whatever like that. And she stayed out there at MD Anderson. She did really, really well. She did everything that she's supposed to do. And she ended up getting a simple cold. And that simple cold just spiraled all the way down. So you all will always hear me say that when most people die and they have cancer, they don't die from the cancer, they end up dying from other causes. But I loved her. She was the sweetest thing or one like that. I mean, she kept to herself. She was very reserved. She only let a minute of different people be in her business. And yeah, she would right before she got like sick, before she got like down sick, she went Facebook Live, and one of my friends that followed her, she's like, Alicia, you gotta go on there. She's like giving you a shout out on Facebook. So I went on there, and she was just thanking everybody that took care of her, and she was personally thanking me and the staff, that took care of her, during her time, and her transition that she's about to get ready to go on hospice, and and things like that, but I just love taking care of her. And when I found that picture, because we ended up taking a picture together, like on one of her treatments or whatever, I'll show you guys. But yeah, it can be hard on them. And everything is like in high doses. or whatever, but they just know when they do stem cell, it has to be a match, 10-10 match in order for them to be able to get it. They do stem cells at UMC. I had another patient that had stem cells. She ended up passing away. Another young lady, we would have been around the same age. That's because she was very, very non-compliant. I guess she thought that Jesus Christ was going to take care of her forever. She did the opposite of what we told her, and it made me so angry because she had these two young babies that depended on her and her husband. And her husband would call and he would like vent to us, the nurses, like, I don't know why she's doing this. She has all these people over here at the house. And I'm like, why are you doing it? You know, you cannot have company. And this is it. And it got to the point where the doctors ended up put her in the hospital, literally. And we had to literally make sure nobody came in the room. She could not have any visitors at all because she was so non-compliant. She would go to Belt and go shop, but it just came and she wasn't even 30 days out from getting her stem cells done. And this lady was out at the freaking mall. She was at the mall, y'all, and made her husband so upset. And how he found out his sister, one of his sister's best friends was out and saw her and took a picture and sent it to the husband. He was like livid, and he called the doctor, and the doctor was like, I need a bed, I need a room, so I'm finna to admit her right now. Right now. That's how serious our oncologists are about it. But she ended up subsiding she ended up with pneumonia. We had to put her in the unit. Her body ended up rejecting the stem cells because she did not do what she's supposed to have done, and she ended up passing away. And where I had other patients that weren't even good candidates for stem cells, they couldn't even get a match. And that's another reason why it made me angry, because I had patients that wanted to live and wanted to be there for their families, and they could never find a match, where this young lady got a whole match and she didn't even do what she's supposed to do. Okay, so this is how the transplant is done. So you guys can kind of like look at that slide. All right, so you look at your recipient. This is the person. They're on the anti-drugs and they get the radiation. Then you have your healthy donor. They get the bone marrow, and it's normally out of the biggest bone is going to be the pelvic bone. They take so much from them, and then they inject it into the recipient. And the recipient normally is supposed to stay in the hospital up to 30 to 60 days, depends on if they're compliant or not. Like I said, my young lady had gotten out and she wanted to do her own thing, and we put her right on back in the hospital. So it's like with the healthy bone marrow, and they kind of help them. Like I said, once again, they have to be a 10-10 match. Okay, and these are your biological modifiers. The body has to be able to respond to the cancer cells, help prevent the body's own immune system. Because remember, once we give them somebody else's bone marrow, our body's going to automatically kick in and say this is something that's foreign. That's just like our patient that have kidney transplants or any other kind of transplant. Bone marrow stem cells is a transplant, just like that. Their body may try to reject it, so we give them anti-rejection medication, and we try to make sure that their body don't reject what we're trying to give to them. But in order for your patient to get the stem cell, you have to do extensive teaching with them so they know what they're supposed to do and what they don't supposed to do when they get it. And so technology has advanced so much. So by the time we as nurses advanced, because it has advanced a whole lot since just me, but by the time you guys get out, it's going to be more advanced for us. This, and they tried to help the patients so their own body won't attack against what we're trying to do. So they're trying to come up with different kind of biologicals that we can start the patient and start taking even earlier prior to them receiving the treatment. Therefore, so they can their bodies won't reject it.